I heard a lot of people that I knew, black people, saying, "Oh, you can't get COVID."
Dr. Ojikutu, you're taking a deep breath here.
I think that there's a lot of misinformation and disinformation out there.
Black Americans were among the least vaccinated during the COVID-19 pandemic, but saw some of the highest rates of the virus. 5 years later, how have attitudes about vaccination changed? And what else have we learned? So, Dr. Ojikutu, I'm going to come to you first with a couple stats here. According to the CDC, non-Hispanic Black Americans made up about 14% of all deaths during the COVID pandemic. About 50% were vaccinated. So, what can explain these disparities?
So I think there are a couple of things that are going on. So first of all, one of the major reasons that Black people and Latinx, Hispanic individuals, as well as Indigenous folks, had a higher rate of death during COVID-19 was because there was a higher rate of racial health inequity in our communities and a higher rate of comorbid illness. If you just want to look here in Boston, Black people die at almost 3 times higher rate from diabetes and heart disease than white individuals in Boston.
And also have a lower life expectancy.
And have a lower life expectancy. I mean, we know that we have a 23-year life expectancy gap across our city if you look at a census tract in Roxbury versus a census tract in Back Bay. And it's not just Roxbury versus Back Bay. We also have these types of gaps throughout our city. So we know that those comorbid illness put us at higher risk from death from COVID-19. Mm-hmm. Unfortunately, because of a lot of the messaging, the failure to message appropriately, the failure to use trusted messengers, the failure to essentially start the process of redeveloping or truly developing trust in communities, working with Black organizations, working with organizations, people who have lived experiences similar to those people who we wanted to get vaccinated. There was a delay in Black people getting vaccinated, but I call it a delay because we ended up closing our gap. And we did that because we focused in on organizations that we knew could be boots on the ground, who actually knew our neighborhoods, who were actually Black doctors, Black nurses, community-based organizations. We really saw a lot of community empowerment, resilience within our communities, people doing the work for themselves. And I think that's one of the important lessons learned.
Mm-hmm. And Adrianne, how did attitudes towards the vaccine evolve over the course of the pandemic?
Well, I think actually there's a lack of appreciation for the heterogeneity in the Black population and maybe Hispanic. So there's the Black population. We're all grouped together as Black, but we're not all the same. And so there could have been language barriers, cultural barriers, but then there's also those historical components, like my family is from the South. The American South. My grandfather was and my grandfather was a sharecropper. So people were referencing the syphilis study at Tuskegee. That wasn't the first time that I had heard about it, but that was for a lot of other Black people who live here. That was the first time that they had heard about it. My grandfather was a sharecropper, so that could have been him. He could have been one of those men who were violated, and during that time.
Mm-hmm. And just for clarification, this isn't where they gave one group the tests for syphilis. Oh, you would explain it much better than me. I'm gonna let you take that.
So they had syphilis. They were already infected. They had the disease, and then when the treatment became available, they did not disclose that. They hid that information from these men who were all sharecroppers in Alabama. They hid that information. The investigators, researchers, hid that information from them so they could see how the disease. The course of the disease in these people. And so they were sick, had died, spread it to, family members and everything like that unnecessarily because they could have just been treated with an antibiotic when the antibiotic became available. And that was it. But the researchers decided not to tell them. And so they could see how the disease, the course of the disease. And so because I already knew that information, because a lot of Black people here already knew that information, or at least they knew something happened that was wrong. They're wary. They said, "No, you're not going to poison me," or and so. But that wasn't the case for everyone. And so I think that it was a missed opportunity to really understand the populations who did not trust the scientific medical establishments, but to understand why there's nothing like genetically about us that makes us inherently vulnerable to diabetes or these other comorbidities. There's nothing there. These are systemic issues, and so we should, as scientists, public health doctors, and everything, we should take the time to understand that so we can address these issues.
Now, I do want to mention, because you talked about how these misconceptions of us being more susceptible because of certain things that are really systematic, that are not necessarily just because you're Black, you have these comorbidities. On the flip side, we know that at the federal level, Health and Human Services Secretary RFK Jr. Has alluded to Black people having a higher immune resistance and therefore needing different doses of vaccinations, such as in the case of measles, mumps, and rubella. Dr. Ojikutu, you're taking a deep breath here. So tell me more about how the conversation about vaccines on the federal level can shape how we respond to public health crises like COVID-19.
So I think that there's a lot of misinformation and disinformation out there. And unfortunately, no matter where that's coming from, it tends to trickle into our communities, and it comes to us in many different ways. Misinformation is sometimes just, things that are said that are just not said appropriately. Disinformation is actually intentional. It's actually meant to lead people in the wrong direction. And unfortunately, at a leadership level, we have things that are being said that are incorrect, grossly incorrect. And I'm hoping that people take it upon themselves, and we've tried to, at the Boston Public Health Commission, to correct and be proactive so that people are actually finding the right sources of information and listening to that. But that goes back to this idea of who do you trust? Who is it that you think is looking out for your best interest?
And who do you think that is for Black and other communities?
Well, I think what my colleague here on the panel just stated, we're a diverse group of individuals, and I do think that we tend to trust people who have the same lived experience as us, who are not just the same skin color, but may have the same ethnic origins. We aren't all the same. And I think that oftentimes we overlook those people in our communities who are actually the people who can spread the accurate information. And this is why what you just said is something, I'm glad you put it out there, because it's completely incorrect. MMR, measles, mumps, rubella, the dosage is the same. The dosage is the same, irrespective of your race or ethnicity. I think having people who are our faith leaders, who are our mothers in our communities, who are our teachers, who are our school leaders, who are our doctors, who get out into the community, who are our community health workers, these are the people that people trust because they see them amongst themselves. They see us. And I think that's what we need to do more of, is have more of us. And this is why the attack on DEI, diversity, equity, inclusion, is so critically important, because if we want this not to happen in the same way, then we need to continue to train at all levels people who look like the people who are most at risk of any disease.
All connected there. So you talk about the next time. Will there be a next pandemic? And if so, what will it look like? Adrianne?
Well, I'm sure there probably will be. There's the bird, they call it bird flu. The avian influenza is circulating now. But I remember when I was working on a master's degree, I was learning about this same virus then. And it was an emerging threat then. And I think that was in like 2010. Or something like that. And so now we see as it's circulating. And so there's always going to be a chance. There are always these, what we call emerging threats. There's always going to be a chance that there's going to be a virus that's in animals now, maybe it's not causing any harm, but as soon as there is a mutation, it can make a jump to a human, and then it'll be able to spread from person to person. There's always going to be that chance. And I think that we missed a lot of opportunities to prepare ourselves for that during the COVID-19 pandemic.
How do we shift that for this presumed next pandemic?
So I think we missed opportunities, but what I would say is that we learned some things and we should be acting on them. So one of the things that we learned is just how important public health infrastructure actually is. So you have people who are well trained and who actually, they can get the data, they know how to use the data, they know how to disseminate the data, people who can get out into communities, people who are community health workers, people who actually know how to communicate public health messages. These are things that we should have learned. And actually, probably towards the end of the, I wouldn't say the end necessarily because COVID-19 is still with us, but as we sort of got through the height of the pandemic, the CDC actually issued a very large grant, public health infrastructure, a grant, billions of dollars that was disseminated around the country to build and to go back and say to ourselves, hey, we haven't for decades been investing in public health, so here, we are going to invest in it. The problem now is that funding and the public health strides that we've made going forward, it's now threatened, And I think that speaks to also when we're talking about science and we're thinking, okay, what's happening with NIH? And if we need these advances, why are we not continuing to invest there? So it's like we take a few steps forward, we learn a few things, and then we take steps, almost 10 steps backwards. And that's the concern that I think all of us in this field have, that's why we may not be prepared for the next pandemic.
So I know that both of you have worked with HIV and working to address the prevention and treatment of HIV. And in many ways, there seem to be some parallels, right, when we think about the way that we have changed the conversation and the stigma around that virus and the prevention and treatment methods that people can take, even changing the culture around getting tested, right? And specifically within the Black community. Still a long way to go, of course, but would you say that we can apply some of those lessons when it comes to responding to something like a pandemic?
I'll say that I feel like there is still somewhat of a stigma associated with HIV infection. Yes, it's better, and people can access treatment, I think, more easily. But I think that is, you hit it, I think, like the nail on the head when you mentioned the stigma, because I think that that's the first thing that needs to be addressed. And just listening to the messaging that we hear about our vulnerability, or our susceptibility to COVID, or that we're more immune, or these things that we hear. People listen to those. So at the beginning of the COVID-19 pandemic, I heard a lot of people that I knew, Black people, saying, "Oh, you can't get COVID," because at first testing, and it was like something that we've heard before. This is not, even specific to like COVID-19. We've heard this before. I read some historical papers about, was it yellow fever, I think? And, this to the same thing. Oh, Black people, they don't get this infection, or at least if they do, they have mild symptoms. And, there's always this messaging that there's just something so different about our bodies that we're going to, respond in a different way, or that it can't affect us, as much. And even HIV, I don't think it's that people think they can't get infected, but maybe they do. Maybe it's or we don't even want to go and get tested. And so by the time people are tested and they realize that they have infection, it's already too late. Or the treatment can't really improve their outcome. And so of course now you see there are more Black people who have more severe infections, or more severe morbidity or higher rates of mortality, because we believe these things. And so I think that that's the first thing that should be addressed. We should be, first of all, our bodies are the same as everyone else's. That's just the truth. Try to get tested. Who cares what anybody else thinks? Try to get tested, get treatment. So you can live, period.
And maybe some of those same lessons to be applied toward any public health phenomenon.
Yes.
Well, Adrianne Gladden-Young and Dr. Bisola Ojikutu, thank you both so much for this insightful conversation.
Thank you.
Thank you.